Hello everyone and welcome to another episode of Heart Success Podcast. Today is the first episode in our series on Cardio-Oncology. In the first two episodes, we will be talking to a hematologist oncologist and a radiation oncologist in an effort to better understand things from the treatment side. And following that, we have a couple of episodes where we will be talking to cardio-oncologists, where they will explain the cardiac manifestations of this disease and related management in greater detail.
We have a guest today with us who is a hematologist oncologist, Dr. Kaushal Parikh, who is going to go over the different drug classes involved in cardiotoxicity when it comes to chemotherapy. And he's also going to explain some of the mechanism of action for these cardiotoxicities.
Dr. Parikh completed his medical training at TNMC Nair Hospital in Mumbai, India, following which he completed his internal medicine residency and hematology oncology fellowship at New York Medical College, Westchester Medical Center in Westchester County, New York. He did a fellowship in thoracic oncology and phase 1 trial research following this at the Mayo Clinic in Rochester, Minnesota, and currently works as a medical oncologist in the Division of Thoracic Oncology and Early Therapeutics at Hackensack Meridian Medical Center in New Jersey. His clinical and research interests revolve around thoracic oncology and phase 1 early cancer drug research. Welcome to Heart Success, Kaushal, and why don't you start us off by telling the audience a little bit about you?
Hey Mahek, it's great to speak with you. A little bit about myself. I am a medical oncologist focusing on thoracic malignancies and early therapeutics. That's phase 1 clinical trials at the Hackensack University Medical Center and John Thorough Cancer Center here in New Jersey.
Thanks, Kaushal. And maybe you could tell us a little bit about you outside of work.
Well, outside of work, typically most of the time is taken by research and writing. But I do like to go out. I do like to run. I do like to, just like most other people, travel. These days, because of the coronavirus, we have, canceled a lot of our traveling plans, which is nice. It gives you some time to spend at home.
Glad you're back in the Northeast. Let's go over some of these drugs. Why don't we start with some of the commonest drugs associated with cardiotoxicity?
And the commonest drug class we associate with cardiotoxicity are the anthracyclines.
Yeah, so anthracyclines, these are some of the most common chemotherapeutic agents that we use. Very potent cytotoxic agents. The five most common ones we use are doxorubicin, daunorubicin, idarubicin, epirubicin, and mitoxantrone. We do have liposomal formulation of doxorubicin, which we'll briefly talk about later. These are topoisomerase 2 inhibitors, essentially. And they do have some other ways of cytotoxicity, such as reactive oxygen species formation or causing direct DNA damage through topoisomerase 2 inhibition. They also inhibit protein synthesis. We do see that these drugs are frequently involved in cardiac toxicities. We feel that the mechanism of action for these drugs to cause cardiotoxicity is it's mediated by reactive oxygen species formation. This leads to lipid peroxidation and myocyte damage, causing fibrosis. Typically, these patients will have heart failure or symptoms of lower ejection fraction. The topoisomerase 2 complex, topoisomerase 2 beta, can also complex with the anthracycline to cause direct DNA damage and myocyte death or cell death. We use anthracyclines most commonly in breast cancers, but these are also drugs used fairly commonly in the hematologic world and leukemias and acute leukemias. Some of the risk factors that lead to cardiac toxicity are older age, pre-existing cardiac disease, female gender, hypertension, history of smoking, history of hyperlipidemia, the usual suspects, previous coronary artery disease. And the one thing that we've noticed is that the cardiotoxicity or the incidence of cardiotoxicity increases with the higher cumulative exposure of anthracyclines. Typically, that's a number of about 450 to 500 milligram per meter square of a lifetime dose of doxorubicin or its equivalent. We always perform a baseline ejection fraction test, typically a MAGA scan or a 2D echocardiogram, prior to starting patients on anthracyclines. My practice is to avoid anthracyclines if the baseline left ventricular ejection fraction is less than 50%, or if these patients have symptomatic heart failure. We also periodically look for symptoms, look for repeat imaging if patients develop symptoms during treatment, which again is not very common because, as I said, most patients are able to tolerate that lifetime dose. Some drugs have been studied for cardioprotection to be used, sort of empirically or prophylactically as cardioprotective agents. Beta blockers, ACE inhibitors, angiotensin receptor blockers. They've been used, but these lack robust data to actually support consistent usage or make it an absolute recommendation. As far as toxicity or managing the toxicity is concerned, we do have one approved agent, that is dexrazoxane, which is an iron chelator, which has been shown to prevent the iron anthracycline binding especially, and prevent reactive oxygen species formation. It is approved as a dose of 10 to 1 dose of dexrazoxane to doxorubicin, and is the only one that is approved. However, deferriprone also has some cardioprotective activity.
Kaushal, just to clarify a couple of things, for us non-oncologists. One was, what does the typical regimen for anthracyclines look like when you're treating patients with, let's say, breast cancer? And when you said
dexrazoxane.
Using dexrazoxane is primarily for prevention of cardiotoxicity.
It's not. It's for when cardiotoxicity happens, and when you know it is because of the anthracycline.
So how would you maybe add that to your regimen? So I was hoping maybe you could tell us how you use these drugs.
So anthracyclines, let's take the example of breast cancers. Typically, you use them on a dose-dense schedule in non-metastatic patients, that is, in patients who are receiving either neoadjuvantly, that is, before their surgery, or adjuvantly, that's after their surgery. They're preferred to be given in a dose-dense fashion. Dose-dense means drugs given at shorter intervals, that is, every 2 weeks, and typically for about 4 cycles. Okay. If these patients do develop, let's say, a patient with metastatic breast cancer who is receiving an anthracycline agent every 3 weeks as a single agent, we tend to not perform routine 2D echocardiograms unless there are some symptoms, or we stop after a few cycles. If these patients develop symptoms, you perform an echocardiogram and they do show reduced ejection fraction significantly lower from their baseline. You suspect, are there any other causes? And then obviously anthracycline is a big elephant in the room. We tend to give these patients doxazoxane. I have personally used it seldom, not very frequently. They either have pre-existing heart disease and are ineligible to receive an anthracycline, or we stop their treatments much before they reach that cumulative 500 milligram dose. That being said, the drugs that we use here in this setting, that's dexrazoxane, these do not guarantee a reversal, and often the cardiac damage is permanent.
You did mention the liposomal formulation. Is that less cardiotoxic?
Yes, the liposomal doxorubicin is known to be less cardiotoxic. Another point I'd like to mention here are the 2 clinical trials which looked at angiotensin receptor blocker candesartan. And those are the Overcome and the Prada trials. The Prada trial showed about a 2% decline in cardiotoxicity when candesartan was used. However, I do not prescribe this to all my patients. We do prescribe ACE inhibitors and beta blockers when the left ventricular ejection fraction declines.
We have another episode that we're doing with a cardio-oncologist where we're going to go over all the data on cardiotoxicity, prevention, treatment. So we will definitely be exploring this further in future episodes. To follow up, the anthracyclines, I think, is the next common class of drugs that we hear about, are the anti-HER2 agents. I was hoping maybe you could tell us about these drugs and explain maybe also how you use these drugs in practice.
The anti-HER2 agents, these are, again, drugs used very commonly in breast cancers, now being used in some GI malignancies as well. We're talking about anti-HER2 antibodies right now. The prototype is trastuzumab. Now we have new ones such as pertuzumab as well. So anti-HER2 agents also can cause cardiotoxicity. This can sometimes be reversible. The risk factors for developing HER2 and HER2 antibody-related cardiotoxicity are, of course, previous anthracycline use, previous radiation, pre-existing heart disease. These drugs are not given concurrently with an anthracycline because there seems to be an additive or a much higher rate of possible cardiotoxicity when used together. The risk of developing cardiotoxicity with the HER2 agents like trastuzumab is about 2.5%. The mechanism of action is not well understood in this case. It would likely be related to HER2 blockade on the cardiac myocyte. We know this from embryologic studies where we see that the role of epidermal growth factor and HER2 pathway is very important in cardiac development. And so we feel that, blockade of this pathway is the reason for, a blockade of HER2 is the reason for cardiotoxicity or cardiomyopathy from trastuzumab. A similar mechanism may be responsible for the cardiac toxicity with pertuzumab, as well as with other HER2 agents. We do have lapatinib, for example, which is a tyrosine kinase inhibitor, as opposed to an antibody. And then we have TDM1, that is adotrastuzumab emtansine, which is an antibody drug conjugate, also used in breast cancer. Like in anthracyclines, we always perform an ejection fraction assessment prior to therapy, typically again a MAGA-scan or a 2D echocardiogram. In different settings, in the adjuvant setting versus in the metastatic setting, we have different ways of monitoring the cardiac function. For example, typically in the adjuvant setting, we tend to repeat the MAGA-scan or an echocardiogram every 3 months for that 1 year of treatment, the 1 year that we use the trastuzumab for. In patients who have metastatic disease, we typically measure the left ventricular ejection fraction at initiation of treatment and then only as clinically needed. Of course, in the adjuvant setting, if someone develops symptoms of heart failure, we will send them for an echocardiogram or a MAGA scan even before, much earlier than 3 months. When we are using these studies for assessment, we must also understand what to do next. So if the drop in ejection fraction is 16% or more from baseline, or if it drops 10 to 15% below normal, we tend to stop the drug and repeat imaging in 4 weeks. In patients who develop symptomatic heart failure, we tend to discontinue the drug permanently.
Moving on to the next class of drugs, I just wanted to go over some of the other classes briefly. I know there's so many different classes of drugs we could talk about today, but maybe just pertinent cardiac adverse events. The VEGF inhibitors comes to mind.
The VEGF inhibitors are interesting. These are, you can have, again, similar to HER2, these can either be monoclonal antibodies such as bevacizumab or ramucirumab, or these can be tyrosine kinase inhibitors. The most common vascular side effect that we have with VEGF inhibitors is hypertension. That's because VEGF itself mediates nitric oxide production and angiogenesis, and and nitric oxide production obviously reduces causes vasodilation and decrease in blood pressure. Therefore, VEGF inhibition, which inhibits nitric oxide, leads to a rise in blood pressure. We always want to treat the pre-existing hypertension before we start patients on VEGF antibodies. The other interesting vascular side effect from these agents is risk of arterial thrombosis and strokes. Because of VEGF blockade, leading to antiplatelet activity. Again, the same nitric oxide pathway and inhibition of VEGF leading to antiplatelet activity and causing arterial thrombosis.
Yeah, these are great points for the VEGF inhibitors. And you mentioned the tyrosine kinase inhibitors. Any relevant drugs?
One of the common VEGF TKIs, a lot of these are not specific TKIs. We sort of call them, multi-kinase inhibitors, such as regorafenib. Some of the other drugs that inhibit VEGF, along with other tyrosine kinase enzymes, are sorafenib or even sometimes pazopanib.
There is another class of drugs I wanted to briefly go with you, and we talk about this in a lot more detail in our subsequent episode where we go over arrhythmias, is ibrutinib. Maybe I was hoping you could tell us when you typically will use this drug and why we're seeing more use of these drugs these days.
Ibrutinib and acalabrutinib, these are collectively two Bruton tyrosine kinase inhibitors, which are used in lymphomas, initially approved in chronic lymphocytic lymphomas, chronic lymphocytic leukemias, and now in other B-cell lymphomas as well. Incidence for atrial fibrillation from these drugs seems to be about 10% depending on the studies that you look at. And these drugs can also sometimes cause hypertension or peripheral edema. The atrial fibrillation is it's very interesting. We feel that the mechanism of action is likely by inhibition of the PI3 kinase AKT pathway in the cardiac myocytes. This also seems to be rather persistent in that it does not resolve often after stopping the agent. The issue arises from the fact that apart from the thrombotic risk of AFib, ibrutinib also by itself increases the risk of bleeding due to its antiplatelet activity. However, we've seen that most cases of bleeding are grade 1 or grade 2, such as petechiae or skin bleeding or subcutaneous bleeding. Major cases of bleeding, such as grade 3 and above bleeding, are well under 10% from what I've seen.
What is the length of treatment for using these drugs? Like if you were using ibrutinib in patients with CLL, how long is the expected treatment duration?
Right. So we typically tend to treat these patients indefinitely till till their disease continues to respond or as long as they can tolerate the treatment for. Either the disease progresses or if they develop intolerable adverse events, in those cases we stop or switch.
Yeah, no, I've been seeing more use of this drug in a lot of these older patients, and we just have to get more familiar with the cardiac side effects.
And these drugs are much, on the whole, this is a much better tolerated drug than several of the chemotherapy agents that we use, especially in the elderly, especially in high-risk patients with CLL, such as a 17p deletion or p53 mutated CLLs. Initially was approved as a second line, but now approved as first line for these patients.
Moving on to another class of drugs, fluoropyrimidine-associated cardiotoxicities. I was hoping maybe you could talk a little bit about those drugs and then how to manage the cardiotoxicity.
Right. So fluoropyrimidines, we've been using them for a long time now. The two classic fluoropyrimidine agents that we use are 5-fluorouracil and it's a prodrug, that is the oral version of 5-FU, which is capecitabine, which gets converted in tumor tissue and other cells to 5-FU. We see that cardiac cardiotoxicity incidence with 5-FU is between 1 and 15%. It's a large, it's a large number depending on the studies you're looking at or the data set you're pulling from. It is the second most common agent to cause cardiac toxicity after anthracyclines. Usually, when you talk about 5-FU, 5-fluorouracil, it's an intravenous agent which is administered as a bolus followed by infusion. We believe that the cardiotoxicity is primarily due to the infusion of 5-FU, and this is mediated by direct coronary vasospasm. So often patients present with symptoms of angina or ACS, such as chest pain. Capecitabine, on the other hand, has a similar rate of cardiotoxicity. This is as I mentioned earlier, this is an orally bioavailable prodrug that is metabolized to 5-FU. And in tumors as well as in other tissue, it uses the enzyme thymidine phosphorylase to convert to 5-FU. The risk factors with 5-FU are also older age, prior radiation. And the one thing that we also see is DPD polymorphism or DPD deficiency. Unfortunately, for patients who have dihydropyrimidine dehydrogenase deficiency, it's not something that we test for usually. We may find out if the patient has immediate, after the first cycle itself, the patient develops this cardiotoxicity or ACS symptoms. Management is typically to discontinue the 5-FU using anti-anginal agents. You obviously are better off talking about anti-anginal agents than I am. These patients may have EKG changes similar to ACS, such as ST deviations, may also develop arrhythmias.
Let's say somebody has 5-FU toxicity and coronary vasospasm. Would you typically re-challenge this patient in the future with the same drug?
Re-challenging these agents, I typically like to stop the 5-FU. Re-challenging is controversial. Only time I would re-challenge if this patient has no prior coronary disease or if the patient does not have any other treatment option, especially in the, if this is an adjuvant or curative intent for treatment. We can switch to bolus. We can attempt to switch to a bolus-only regimen instead of an infusional regimen. And a lot of times these patients are concurrently given aspirin or calcium channel blockers, aspirin and calcium channel blockers.
Yeah.
FDA has also approved another agent for early onset severe toxicity, that's uridine triacetate. This can be used if there is no benefit with anti-anginals. What happens is that the UTP, it competes with the 5-FU and the UTP molecule, the compound FUTP, to incorporate into the RNA. And this uridine triacetate competitively inhibits this FUTP to incorporate into RNA and cause cardiotoxicity, or any toxicity rather.
Great explanation, Kaushal. What type of cancers are we using 5-FU for typically? And is there a typical regimen for this drug?
5-FU is used primarily in GI malignancies, a lot in colorectal cancers. We also use this in gastric cancers and pancreatic cancers. Typically, it's a part of a regimen, of a multi-drug regimen, such as FOLFOX, where it's 5-FU is used with leucovorin for protection and with oxaliplatin. Other regimens include FOLFIRI or FOLFIRINOX or FOLFOXIRI, primarily in GI malignancies. Capecitabine has been approved for breast cancers. In the adjuvant setting, we tend to use between 3 to 6 months of 5-FU based treatment. In the metastatic setting, we continue maintenance 5-FU following the initial 3 to 6 months of combination chemotherapy regimen.
The next class of drugs I wanted to discuss were the taxanes, because they're pretty commonly used in several of the solid organ tumors.
Yes, taxanes, these are antimicrotubule agents. They promote tubulin polymerization and they disturb cell division. So they basically cause increased polymerization of tubulin. Two common ones that we used are paclitaxel and docetaxel. These are used in a wide variety of cancers, including breast cancers, lung cancer, prostate cancer, gastric cancers. Paclitaxel also has a nanoalbumin-bound particle, an albumin-bound version called NAB-paclitaxel, which is better tolerated than paclitaxel. Most of these patients who come to you with asymptomatic sinus bradycardia, about 30% of all cardiotoxicity will be asymptomatic sinus bradycardia. There can be some additive toxicity in patients who receive combination chemotherapy with the taxane and an anthracycline. And docetaxel, on the other hand, can cause some conduction abnormalities, angina, or heart failure.
I want to spend the latter half of our conversation today focusing on two specific drug classes. First, the immune checkpoint inhibitors, or the checkpoint inhibitors, which have really changed the field of oncology as we know it. The second class of therapies I want to talk about are the CAR T-cell therapy, a very novel way of treating cancer, and is associated with some cardiovascular side effects. So let's talk about these relatively newer therapies.
Yeah, immune checkpoint inhibitors, or just checkpoint inhibitors as we call them now, are this new class of agents. Well, not so new anymore. We've had these drugs available for about 7-8 years now at least. These are essentially agents that remove the inhibitory signals of T cell activation, which enables T cells to, continue to proliferate and mount an effective anti-tumor response. Think of it this way. These are checkpoints. These are brakes on the immune system so that your immune system does not end up, causing a lot of autoimmune actions, autoimmune responses. Blocking these checkpoints or blocking these brakes essentially unleashes the immune system and, to mount an anti-tumor response to cause, cytotoxicity and cancer cell death. There are two classes of immune checkpoint inhibitors that are currently approved, and several more are being studied. Several more are in the late phases of clinical development right now. The two that are approved are anti-CTLA-4 antibodies, and then you have anti-PD-1 and anti-PD-L1 antibodies. Let's talk about anti-CTLA-4 antibodies first. So CTLA-4 expression, it's really linked to T cell activation. So when you have T cells who get activated by an antigen, antigen presenting cell, which is either the tumor cell or an antigen presenting cell, presented by the major histocompatibility complex to the T cell receptor, it induces a cascade of signals in that T cell. One of them is a co-stimulating signal, which is mediated by a CD28 molecule on the T cell, which essentially binds to B7 antigens on the antigen presenting cell to sort of mount the immune response. So CD28 causes co-stimulation of this T cell and leads to cytotoxicity. CTLA-4 is upregulated at the same time in order to blunt this immune response, which is a protective mechanism. So the CTLA-4 will competitively inhibit the CD28 binding, competitively inhibit this co-stimulation. Therefore, blocking the CTLA-4 removes that brake on the T cell, on the cytotoxic T cell, which leads to its cancer cell death activity. The other class of agents are the PD-1, PD-L1 antibodies. This is another checkpoint that we see in which the PD-1, which is found on T cell, binds to the PD-L1, which is the PD-1 ligand on usually the antigen presenting cell or the tumor cell. This also leads to blunting the immune response, the binding of PD-1 and PD-L1. It's essentially telling the immune cell that this is a self antigen of a self tissue. The immune cell should not go attacking it. The way we blunt this response is by blocking the PD-1 on the T cell or the PD-L1 on the tumor cell with antibodies. PD-1 antibodies that we have available now are initially the nivolumab and pembrolizumab, and now we also have durvalumab. And the PD-L1 antibodies are atezolizumab and nivolumab. Again, there are others as well which are being studied or approved, such as semiplimab. Every company is coming with its own iteration of a PD-1, PD-L1 antibody or a CTLA-4 antibody. The CTLA-4 antibody that we have on the market right now is ipilimumab. These drugs have a very peculiar side effect profile, in which the side effects of these drugs are essentially because of the immune activation. So we call this immune-related adverse events. Typically, most patients are able to tolerate the drugs fine, and most common side effects are dermatologic or thyroiditis. Other side effects that are of significance, and we see them and we worry for these side effects, are pneumonitis and colitis. As we use these drugs further, we saw a new range of side effects, including autoimmune hepatitis, interstitial nephritis, myocarditis, cardiomyopathies, encephalitis, hypophysitis as well. But these are still not as common.
So basically, to summarize, there are pre-existing breaks within our immune system which prevent our immune system from attacking self-tissue. However, cancer cells trick the immune system, take advantage of these breaks for their own protection, their own survival, stopping our own immune system from destroying these cancer cells. And these checkpoint inhibitors wake up your immune system again with collateral damage of autoimmune side effects. My question is, do you sometimes use both these classes of checkpoint inhibitors in the same patient? And if yes, does that increase the risk for autoimmune complications, especially the severe complications such as myocarditis?
Yeah, that's a great question. So yes, the combination of CTLA-4 and PD-1 antibodies has been approved for melanoma, and it's being studied for other indications as well. It was approved for melanoma. We've used it in small cell lung cancer. There's new data coming about its use in mesothelioma. There is also some data of its use in non-small cell lung cancer, not strong data. So the other drugs such as durvalumab and tremelimumab also being studied currently in clinical trials. But the strongest indication for using an anti-PD-1 and anti-CTLA-4 antibody comes in melanomas, where these drugs are approved. And we do see a higher rate of adverse events, especially colitis and pneumonitis with these agents when used in combination than when used individually.
Okay. What does the typical course of therapy look like?
These drugs are by and large approved in the metastatic setting, both PD-1 as well as CTLA-4 antibodies. They have been approved now in the maintenance setting as well, following concurrent chemoradiation, for example, in stage 3 non-small cell lung cancer, in which we give durvalumab for up to a year. But most clinical trials with these agents studied these drugs for about 2 years, and we stopped at 2 years. So in my practice, I stopped these drugs at 2 years. Ipilimumab, when it's given in combination with nivolumab for melanomas, we tend to give 4 doses of ipilimumab. But as far as the PD-1, PD-L1 drugs are concerned, we tend to stop at 2 years. The most widely used of these agents is pembrolizumab, which I believe has most indications amongst all checkpoint inhibitors. And all clinical trials of pembrolizumab have a treatment end date at 2 years after initiation. And we've seen great responses with these drugs. In fact, we recently, late 2019, we saw the 5-year survival data for non-small cell lung cancer patients who were treated with single-agent pembrolizumab. We were astonished to see a survival rate, 5-year rate of about 20 to 22%. And mind you, this is after 2 years of treatment. So, these patients have 3 more years without the immunotherapy treatment, maybe on some other line eventually. But 5-year survival for lung cancer was historically low, and now with these agents, we've managed to improve that to over 20%, which is highly encouraging. As far as the side effects are concerned, on average, a median time for side effects to develop is about 9 to 12 weeks, but we have seen these side effects develop much later in the course, even at 6 months after starting treatment, or sometimes even after stopping treatment. But on median time is about, I would say about 6 to 9 or 9 to 12 weeks after initiation of treatment. Usually, the way to treat these side effects initially is with corticosteroids, which is typically in my practice just prednisone 1 milligram twice a day, or an equivalent oral or intravenous equivalent. And if the side effects do not resolve, or if they continue to get worse, I do not hesitate to give these patients infliximab as the next line of treatment for these adverse events. Very rarely, we've also had to use other immunosuppressing agents such as mycophenolate or cyclosporin, but typically patients respond to steroids. The one important point that I would like to mention about the cardiac effects of these drugs, since I believe that would cater most to your listeners, There have been mice models, studies in PD-1 and PD-L1 deficient mice, which have very high rates of dilated cardiomyopathy and autoimmune myocarditis. This sort of gives us a lab validation or mouse model validation of the cardiac effects of these drugs. While these are not very common, one should still be aware and be cautious about this particular side effect of these agents. Typically, my workup for these patients would include an echocardiogram, an electrocardiogram, and BNP levels. Of course, with an immediate consult to our cardiology colleagues, we tend to stop the immune checkpoint inhibitors for these cardiac effects as well, and treat them with steroids, often over a prolonged taper. We are looking at 4 to 8 weeks at least of steroid taper. I tend to not restart these medications for any grade 3 or grade 4 side effects, cardiac side effects, which means patients having symptoms at rest or severe symptoms even at minimal activity. Rechallenging with these drugs is a little complicated. We have some new data showing that about at least a quarter of these patients will develop toxicity again on rechallenging, especially if they had grade 1 or grade 2 effects. For grade 3, grade 4 side effects, more severe side effects, I tend to not restart these agents.
Yeah. Thanks. That was great, Kaushal. I will just add that while this is an area of active research, there has been some data published on the incidence of myocarditis within this checkpoint inhibitor population. We believe that the incidence of checkpoint inhibitor-related myocarditis probably is in the range of 0.04% to 1.14%. However, the associated mortality of severe myocarditis is 25 to 50%. These numbers get worse when you're talking about combination checkpoint therapy, where the incidence is almost twice as much and the mortality is also significantly higher. So while uncommon, it can be quite severe and fatal. In one meta-analysis that included 22 trials of PD-1 and PD-L1 inhibitors of lung cancer, the incidence of myocarditis was 0.5%, basically 1 in 200 patients. But the incidence of other cardiovascular toxicities is also quite high, ranging from 0.7 to 2%. These toxicities include pericardial tamponade, myocardial infarction, stroke, cardiac failure or heart failure, and cardiorespiratory arrest. We believe that a majority of these complications will happen within the first 3 months. 80% of the complications are probably within the first 3 months. But you may see late complications over a year, year and a half out on therapy. We may have to dedicate a separate episode just to talk about checkpoint inhibitor myocarditis because it's a whole different beast of its own. I've dealt with cases where awareness was most important because time is key. Identifying myocarditis early, stopping the therapies, and starting steroids early is probably most important to survival. Kaushal, maybe we can end it with Carty therapies.
Yeah. Carty cells are extremely exciting right now for all of us, and this is the culmination of about 3 decades of work by brilliant scientists all over the world, actually. These are genetically engineered T cells, in which the patient's own T cells are extracted and genetically engineered in vitro to express a specific receptor to an antigen which is exposed on the tumor surface. And this receptor is called the chimeric antigen receptor, and hence is CAR T cells, chimeric antigen receptor T cells. So when a patient, we take the patient's T cells, we do leukapheresis, and get the patient's T cells, and these T cells are then treated with a lentiviral vector, which has the genetic material that you want the T cells to present at the surface. Typically this includes a receptor to bind to the tumor antigen, and that receptor is at the surface of the T cell, And that receptor then also needs stimulation signals such that when the binding of the T cell and the tumor cell occurs, there are signals to the T cell to cause cytotoxicity, to activate the T cell, to expand the T cells for T cell proliferation. And typically, the receptor is therefore joined with a zeta chain of CD3. Now, your viewers may remember CD3 from their basic immunology as a marker for T lymphocytes. And this is this CD3 upon activation activates the T cell. This formed the framework for first generation CAR T cell. Now, the issue with this generation, with these cells, was that the responses were there, but they were short lasting. And you needed another signal, another activation signal to produce more durable responses as well as memory responses, so that these cells can stay for a long time and continue fighting any tumor that may evolve at a future time as well. This led to the rise of a second generation CAR T cell. In second generation, there's another stimulatory signal, a co-stimulatory signal along with the zeta chain of CD3. And this can be either CD28 or another protein known as 41BB. So these also activate the T cell a little further and lead to increased proliferation, as well as provide the T cells with anti-apoptotic functions. There are two agents approved, which are approved by the FDA for non-Hodgkin lymphoma and acute lymphoblastic leukemia. These both are CAR T cells against CD19, which is frequently seen on precursor B cells and these hematologic malignancies. The first one is tisagenlecleucel, and the second one is axicabtagene ciloleucel. These names are quite a mouthful, but we've seen extraordinary responses with these agents, up to 85% responses seen at 3 months, which includes complete and partial responses. Based on this, in heavily pretreated patients and patients who've had other lines of treatment, CAR T therapies have been approved. And now there are many more CAR T therapies under development. There are CAR T therapies for multiple myeloma. There are CAR T therapies for other solid tumors, which are also being studied, not yet approved, but hopefully in the coming few years, we will have more options available for patients with solid tumors as well. So when a patient is getting ready for treatment with CAR T, we initially take their T cells, and it takes a few days to genetically modify their own T cells and expand them in vitro. Before infusing those T cells again into the same patient, we tend to give the patients lymphodepleting therapy to deplete their lymphocytes, their immune system. And this is typically very high doses of chemotherapy. And that's why these patients are extremely immunosuppressed. They are pancytopenic. They have a huge potential of getting severe bacterial infections, severe sepsis, can also lead to death, sometimes fatal infections. These drugs have been tried in patients who've had multiple lines of treatment for their malignancies, and overall responses have been seen in about anywhere between 70 to 90% patients with these drugs. They also have median progression-free survival advantages, median survival as well. Duration of remission is typically about 10 to 12 months. So we do see that these patients tend to have recurrent disease despite CAR T therapies. And hence we have third generation and fourth generation CAR T therapies in development right now.
You mentioned about the pre-treatment prior to reinfusing the CAR T cells back into the patient. Pre-treatment with lymphodepleting agents and the high risk for infections. What are some of the other side effects of CAR T therapy, specifically focusing on some of the cardiovascular side effects?
These drugs are, very toxic, and they need to be given in an inpatient setting in in a closely monitored setting. Most patients develop a Florid cytokine release syndrome with these agents. Can be seen as early as the next day after infusion of these CAR T cells, seen in about 80% of the patients. This massive cytokine storm, you tend to see hypotension, fevers, altered mental status. Often they get very sick, and this can be fatal. The other side effects that we see with these CAR T therapies are neurotoxicity, often presenting with something as mild as headaches or delirium to florid encephalopathy. Again, seen in a vast majority of patients, in about 65 to 70% patients may develop neurotoxicity. Most of their cardiac effects are probably secondary to the cytokine release syndrome, leading to hypotension, which is by far the most common cardiac adverse event, tachycardia, certain arrhythmias, QT prolongation has been seen. We also seen heart blocks.
Thank you, Kaushal. That was a great description on how these therapies work and their toxicities. I learned a lot from you today, and also I am very relieved that I chose cardiology because things are a lot less complicated. To summarize, some of the major side effects from CAR T-cell infusion are a result of the cytokine release syndrome, ranging from neurotoxicity to renal toxicity to hematological toxicity, constitutional symptoms, and of course, cardiovascular toxicity that you just mentioned. There was a recent paper in JACC Cardio-Oncology which really went into detail about a center's experience and protocol when it comes to monitoring for these cardiovascular toxicities, right from going to getting baseline EKGs and biomarker information on patients being considered for CAR T-cell infusion, to monitoring for cardiotoxicities post-infusion, namely profound hypotension, arrhythmias, evidence for heart failure, and really high-grade, severe cytokine release syndrome. Management in these situations may include supportive care to using anti-inflammatory medications like IL-6 inhibitors, such as tocilizumab, or in some cases even steroids, in addition to specific management of the cardiovascular issues. We will go into greater details on these very specific and relatively niche area of cardiotoxicity post-CAR T in a separate discussion with a cardio-oncologist. Thank you so much for your time, Kaushal.
If you enjoyed our episode, don't forget to like, subscribe, and give us a high rating, as it helps other listeners find us. You can leave your suggestion for topics, critiques, things you think we can do better. You can email us at heartsuccessteam@gmail.com. You can actually find us on our website at www.heartsuccess.info. Our website now also provides links to all the podcast providers where you can listen to this episode. You can find us on our Facebook page at Heart Success Team, or you can always reach me on Twitter at CardioBro.